Good evening, everyone. On behalf of Heartlines and IACTA West Bengal, it gives me to immense pleasure to welcome you all in the episode 6 of our ECMO Essentials mini series. The ECMO is no longer just a rescue therapy. It has evolved into a bridge to recovery, a bridge to surgery, and sometimes a bridge to hope itself. And when it comes to congenital cardiac diseases, ECMO becomes even more essential, more delicate, and more demanding of precision and teamwork. So today's topic is ECMO in congenital cardiac disease is particularly very significant in our present scenario. There are a very small patients who actually most having most valuable hearts and often our most challenging physiological puzzles, they are actually different cases for all of us. Managing ECMO in this kind of populations require not only technical expertise but also a deep understanding of complex cognitive physiology, the timing, the multidisciplinary coordination. So we are truly privileged to have with us Dr. Kishore Jayanti, an esteemed expert whose experience and insights in this field will undoubtedly enrich all of us. His perspective will help us to understand not just how, but the why behind the ECMO decisions in congenital cardiac care. So I encourage everyone, please actively participate, reflect, and engage in the discussion because ECMO is, as in medicine, learning never stops. So, with that, it is my honor to invite Dr. Kishore Jayanti to begin today's session. Sir, thank you very much, and let us begin the session.
Hello, thank you for the kind introduction. Good evening, and let's start the topic. Okay. So, ECMO in congenital heart disease, we'll just go through like indications and management. Basically, indications in congenital heart disease is like more of objective indications and anatomical indications and physiological indications. Okay, we'll just go through some slides in the beginning, starting from statistics, and then go through some physiology. I'll add up some literature which is supportive evidence for a few of the slides. It's not changing. Yeah. So it's basically used for preoperative stabilization when when there is low cardiac output or the patient is hemodynamically unstable, and it's used for post cardiotomy in low cardiac output after the surgery, and it is used as a rescue therapy for as ECPR, like whenever the patient has a cardiac arrest and is unable to be recovered from the ROS is not achieved, and it is also used for as a bridge to ventricular assist devices or cardiac transplantation if the cardiac recovery is not expected after a certain period of ECMO. So this is not the current statistics, just a few year to couple of years old back statistics, where you can see that overall also statistics show cardiac recovery of survival of only 48% in the neonatal group and ECPR of only 29%, whereas in pediatric group it's slightly better, 63% and of cardiac all overall cardiac patients, and ECPR is only 38%. But if it comes to the SWAC also group, like this, we come under SWAC also, the Asian group and like Middle East and the countries as well as India, Indian subcontinent. So it's only 40% in both cardiac and ECPR in neonatal, whereas only around 54-56% in the pediatric population. So it's still low, and we still need to improve a lot on these. So, what are the peri-procedural indications? In neonates with total anomalous venous pulmonary venous obstruction or the pulmonary venous return obstructed TAPVCs and TA like where they present like a hyaline membrane disease. Basically, if you see the X-ray, it's all ground glass and whitish, and it looks like a hyaline membrane disease of newborn. And usually, pediatricians keep giving or neonatologists they tend to give surfactant in that situation, looking at the X-ray, thinking that it's a surfactant deficiency. But if you have a strong suspicion, you actually screen and once it's not improving with surfactant or it's you have a suspicion of congenital heart disease, you have to screen as soon as possible to not miss this important pathology, because we can easily correct this. However, if the patient is very unstable before going on to the surgery, we'll have to stabilize them by putting them on a CPB or ECMO, and then stabilize the patient, especially if they have a poor tissue perfusion or high lactates and low mixed venous saturations, or or something else like infection is there, where you will have to treat the infection part, or some metabolic disorder is there which is responsible for the acidosis. You will have to treat all those, correct, optimize the status, and if sometimes they will have multi-organ dysfunction. So try to stabilize all that, and once the hemodynamics are better, you can switch over them to you can actually push them to surgery. And likewise, it's also in transposition of great arteries with inadequate mixing at the atrial level or the PDA level or the ventricular level. Usually in TGAs we have. So in TGA, transposition of great arteries, usually we have, you know, the TGA with intact septum or TGA with a ventricular septal defect. The mixing is usually at the PDA level or the atrial septal defect level. And the best mixing is at the atrial septal defect level, because there we have there is no much pressure gradient or the difference between left and right atriums. Whereas it is all of the desaturated blood comes from the PDA. There is a bidirectional shunt, but most of the blood comes from PDA towards the pulmonary artery from the aorta, and then gets oxygenated and comes back to the left atrium. And then there is a mixing from between the left and right atrium. So whatever blood is mixed adequately after getting oxygenated in the lung, that goes back to the systemic circulation. However, if there is a poor mixing, there will be, whatever reason it may be, there will be very severe hypoxemia, and that leads to hyperlactatemia and all that malperfusion, all that going on. So, in that case, also, we'll have to stabilize. If the surgery is delayed for some reason, we have to stabilize on ECMO and then take them for surgery. So likewise, there are so many other causes like Al Kappa, where there is left anomalous left coronary artery from the pulmonary artery, or there is Epstein's anomaly with circular shunt following the like BT shunt, or wherever the pulmonary valve is incompetent. And there are other cyanotic heart diseases like tetralogy of Fallot with severe cyanotic spells. So many reasons like that. And coming to like post-op perioperative. So during surgery, usually we have some insult occasionally, where because sometimes you have you clamp off you put them on bypass, you do the aortic cross clamp, and you also in specifically some cyanotic diseases, and what happens is there is a severe poor pulmonary blood flow situation, or the low pulmonary flow situation like tetralogy of Fallot or pulmonary atresia, where you put them on bypass and then come out of bypass. There is a lot of reperfusion into the lungs, suppose there is an aortic arch repair, hypoplastic aortic or interrupted aortic arch repair, where you have a lot of yeah, a lot of we have to repair the aorta. You put them on by aortic clamp, so that what happens is the blood perfusion, the perfusion to the lower body is impaired. In that situation, when you correct and come out of bypass, there is a reperfusion going into the lower body, and so what happens is there is a injury, a reperfusion free radical oxidation injury to the tissues. In that situation also you find a lot of malperfusion to the tissues and low output situation. So sometimes there will be inadequate cardioplegia or myocardial protection. So in that case also we need to stabilize them by putting them on ECMO. Also, there will be some myocardial edema leading to inflammatory response or severe tissue, like the whole muscle will be myocardium will be filled with edematous tissue, and then you don't have, you hardly have any cavity, and there is also sometimes septal dysfunction. So in that situation, we have to stabilize them. And sometimes you have refractory arrhythmias like junctional ectopic tachycardia. So what are the criteria for commencement of ECMO? There's hypotension despite two maximum doses of vasopressors of inotropic score exceeding more than 25. Low cardiac output with evidence of malperfusion of organs as evident by persistent oliguria or diminished peripheral pulses, constricted arterial trace, a low mixed venous saturation, a raised arterial venous DO2 gap, lactate level of 4 or persistently rising trend of lactate despite optimization of preload and afterload and other maximal medical management, and refractory arrhythmias with low cardiac output state and refractory pulmonary arterial hypertensive crisis. So what happens is in pulmonary arterial hypertensive crisis, usually, this is seen when in left to right shunts, like AV canal defect or AP window or multiple VSGs or TAPVCs sometimes. And in these situations, whenever there is a high flow situation in the preoperative stage, these people, once you close, you repair and come out due to the addition of CPB related injury and inflammatory mediators and leukotrienes coming into the lung and all that stuff. So you have reactive pulmonary artery hypertension. So in that situation, sometimes when you do suction or put them to some painful stimuli, like or do an X-ray or echo, some kind of procedures will stimulate a pulmonary arterial hypertensive crisis, which is evidenced by sudden rise in the CVP, desaturation, and no pulmonary blood flow going. The pulmonary vascular spasm occurs and RV failure occurs. There is a septal push. LVEDP is increased. There's nothing much going into the left side, so diastolic pressure falls, LVST changes, and patient will arrest. So in this kind of situation where it doesn't respond to the medical management, we have to go on to ECMO. So what are the consequences of delay in ECMO initiation? So you can have myocardial infarction of right ventricle in tetralogy of Fallot if you delay going on to the ECMO when required. Or there is sometimes high right ventricular end diastolic pressure is seen, leading to compression of coronaries because the coronaries are just beneath the myocardium. So if there is a high RVEDP, it usually it compresses and then the coronary blood flow is compromised. You also see some coronary ischemia in post-arterial switch. If there is a kinking of the coronaries or some thrombus developing in the coronaries, because in TGA what we do is you completely transfer the coronary arteries after the along with the aorta, and so if there is some kind of stretching or kinking or thrombus, etc., you have coronary ischemia, and which leads to severe dysfunction and severe MR and all failure. Okay, in this situation, you will ultimately have to go back to surgery, but for stabilization, we have to put them on ECMO. So PAH crisis I already mentioned. Poor, and sometimes you have a left compliance of the ventricle is very low. So the left ventricle is not able to take volume after the surgery. The systolic function is good, but there is a poor left ventricular compliance, which leads to back pressure and pulmonary edema. And there is also refractory arrhythmias like ventricular tachycardia, junctional ectopic tachycardia, all these leading to tachycardiomyopathy. Again, that can become an indication. And sometimes toxicity following drugs, which leads to sudden cardiac arrest or refractory arrhythmias. And sometimes you have a severe vasoplegia due to intense inflammation in the surgery, which can also demand ECMO. We'll come straight to case. Okay, we'll talk about a case. So, it was a 2-month-old baby underwent arterial switch operation for TGA, VSD, pathology. He had an onset of hypotension with gradual worsening in 4 hours following surgery. The BP, which was like 65 systolic, came down to 40 soon. And despite a volume optimization, usually what we do is we insert a LA line just to monitor the LA pressure continuously, not to exceed like at least 8 to 10. And so we try to keep the LA pressure in single digits and manage this patient. So if the LA is very low, we keep giving slow volume. The LV may not take enough volume because it's like a borderline LV because it's not used to the systemic circulation. So that all we optimize. Still, despite that, if there is a problem and despite the inotropy, so this patient had this. However, there was no bleeding from the drains. That indicates that there is no volume issues, but it was more like a myocardial issue. So echo showed no pericardial collection, so no, there's no sign of tamponade. So there is severe global LV dysfunction, no regional wall motion abnormality. That means, what does it mean? That means there is no coronary issue, because if there is a coronary issue, there will be some regional wall motion abnormality, which is not seen, and there is no PAH. That means what does it indicate? That there is nothing much residual to correct. Go back to surgery. That means if there is a coronary issue, we will go back to surgery for correction. But there is nothing like that. There is no PAH, no other bleeding or any other tamponade, etc. So, but the inotropic requirement is very high. Adrenaline is 0.28, globutamin of 10 mics per kilo per minute. And so inotropic score is almost touching 40. So you see the rhythm is very bad. So next 10 minutes, there was almost crashing situation. So the cannulation was done by opening the chest. It's a 3.2 kilo baby. So we did a cannulation of central ECMO. We can also do peripheral ECMO via the neck by using carotid artery and internal jugular vein. But because it's a post cardiotomy, we chose central ECMO. Right atrium was cannulated, the 14 French, and aorta cannulation of 12 French cannula, and put on CPB. Um, Due to emergency, because CPB was initially available, so we just directly put on the CPB pump. Later, after some time, once the ECMO is primed and all, we converted to ECMO. So you can see in this picture that there is a CPB machine here on the left, and then the ECMO behind this, there is an ECMO machine. So patient was first put on this and then went on to ECMO later. So how we choose cannula size is just a rough guidance chart for both neck, groin as well as central cannulations. Okay. So we used 1/4 tubings in the in the babies, because in adults we use 3/8, but in pediatric in neonates we use 1/4 tubings, especially below 20-25 kilos. Definitely we go for 1/4 tubings. So you can see that we are cannulating, transitioning from CPB to ECMO, and then this is a X-ray after cannulation in the. Already the cannulae were in when we cannulated the CPB. Later we converted. So this is basically a right atrial cannula, and you can see one aortic cannula here, and the bent one is the LA vent. We'll talk about that later. I don't know if this video is going to play or not. No. So anyway, so that's fine. So this is an open chest where you can see the heart basically is very weak, and then we cannulated there. We are unable to open this here. So the flow was it's a 3 kilo baby. So initially we went to 4.4 liters, which is more than, it's around 12 3, like 130 mils per kilo per minute, or 140 mils per kilo per minute. So which is should be adequate for the perfusion of the tissues. The lactate, which was initially at 11.2 millimoles before the ECMO, reduced to 6.2 immediately within like an hour or so. And then gas exchange was satisfactory. The mixed venous saturation increased from 25% before ECMO to 75% after the initiation gradually. So the mean VP also improved from 2025 to pre 250 mean on post ECMO. So usually what happens is there is no ejection much, so you don't see much of systolic diastolic difference. You just have to depend on the mean BP, and it is until recovery you don't see a pulse pressure. The pulse pressure comes up only during recovery, so you will mostly depend on the mean blood pressure. So now what is the target, and we let's talk about the flow. So targets is systemic venous saturation of more than 70% in biventricular circulation. And of course, this is a little complicated. I don't know, I'm talking too much about congenital heart disease, but yeah, some of you might be already familiar. But in biventricular situation, we have like four chambers. In a single ventricular situation, you have only like a single ventricle, which is essentially like a hypoplastic left heart or a hypoplastic right heart, where it's like a only one ventricle supplying circulation to both pulmonary bed as well as the systemic vascular bed. So in that so in that situation, anyway, there is a lot of mixing. So we do not target more than like we can target lower, that is more than 50% of mixed venous saturation in single ventricle. So the tissue perfusion is indicated by low lactate or the decreasing trend of lactate. And the adequate mean arterial pressure is targeted as per the specific agent target while addressing afterload on of ECMO and left ventricle. So what happens is mm, we need a adequate mean arterial pressure, but we do not we do not give too much importance to arterial pressure itself on its own. We need to have a combined approach. That is, the flow should be adequate to the tissues. That is indicated by low lactate. So as long as the lactates are coming down, we are happy with the flows. If the lactates are not coming down, we have to increase the flows somehow. So how you will achieve the tissue perfusion is, sometimes we will have to add an NTG or sodium nitroprusside to reduce the afterload to the left ventricle, so that we can increase the flow as much as we can, 120, 150, up to 200 mils per kilo per minute also we can increase, so that the tissue lactate will start coming down. For that, you will have to facilitate by reducing the systemic vascular resistance by introducing the vasodilators, and that will also help in recovery. Because once the tissue, and first thing, the tissue perfusion improves, second thing, it also reduces afterload to the left ventricle. That's how the LV gradually recovers. Okay. So now there is the second issue. There is also afterload from ECMO to the left ventricle. So ECMO causes afterload because all the flow coming back to the aorta is, part of it goes back onto the LV also. So if you are giving high flow, if you do not reduce the systemic vascular resistance, back there will be back pressure on the left ventricle. So that leads to myocardial stunning. So that means whatever already the ventricle is very poorly ejecting, or sometimes, of course, sometimes it's totally stunned or flat. But it will this whatever this ECMO flow is coming back, it will not allow the heart to recover, because it's some is going back and causing stasis in the left heart. So for that, you will have to do two things. One is reduce the afterload by giving SNP or the NTG, and reduce the systemic vascular resistance. The second thing is introduce a LA or LV vent, so that you will remove the stasis from the left atrium and left ventricle. That part we will talk in the next few slides. So the other goals are to reduce the CO2 gap between venous and arterial blood gases. So if you see the CO2 in venous and artery, so usually the gap should be narrow. If the gap is like 10, 20, 15 or so, that means the gap is very high. It means there is a sluggish circulation. So that gap has to come down. And we also should target low left atrial pressures, like below 5 to 6. So that means that left atrial pressure is not high and the ventricle is not distended. So, and the stunning part has to be addressed promptly. So coming to the values, you in a neonate we go up to 800 to 120 mils per kilogram per minute, but we sometimes have to go up to 200 mils per minute also. Can also, you can target a mean of 40 to 45, but at some 60 is high, but sometimes we go, but usually we keep around 40 is, so, and 35 to 40 is actually enough. And in infant up to 50 to 50, 65 map, and pediatric age group around 60 to 70 maximum. In fact, I'm putting the highest numbers, but the higher number is not essential. The flow is more important than the blood pressure as such. And mixed venous saturation and lactate. These are all the targets for us. So what happened? Coming back to the case, if there was flow reduction after 1 hour to 0.25 liters per minute from zero point 0.4 liters per minute, with a drop in mean BP to 38. And there were some drains bleeding via the drains later. Initially, there was no bleeding, but later there was some bleeding seen from the sternal site and oral cavity also. So it's everywhere bleeding. It's not just one side. So there was some blood started initially, and then ACT was more than 350, so heparin was stopped. So and there was thrombocytopenia seen in the lab, slow fibrinogen. So we transfused all that, whatever came back, like cryo, SDP, and all that. Then gradually flow stabilized. So it's not a surgical bleeding; it's a medical bleeding. So once we identified and stabilized, the flow also stabilized to 0.39 liters per minute. So let's go to statistics. The bleeding is in post-cardiotomy or say congenital heart disease is more seen in with longer CPB times, pre-ECMO mediastinal explorations, initiation of ECMO within 24 hours following surgical repair. So these are the high risk factors because following repair, the tissue is very raw and the suture sites bleeding and something else. There is a lot potential for high risk for bleeding. So the what is the strategy for this is usually we try to come off the CPB and then give protamine tranexamic acid and wait for at least half an hour or so, and then try to control the or get the hemostasis and again go back on ECMO. There will be some insult, but this is a better strategy if your patient is tolerating coming off CPB. But if your patient is not tolerating coming off the bypass, then you will have to straight away go on to the ECMO without heparin and then just wait on that. And you can also give some partial protamine if you think that the cannula are not going to clot. There's too much of coagulopathy. You can give partial protamine. So you'll have to balance all these things. You can also use your viscoelastic testing like TEG or ROTEM so that you can optimize your blood products and choose the exact product required like platelets or cryo or FFP, whichever it is. So if you see these statistics, mostly it's a neonatal age group which has more complications by age and structural heart disease and the surgical patients have more bleeding than medical patients. So organ monitoring, we'll come to the organ monitoring. So what are the targets in this? Usually we keep 180 to 220 seconds as the ACT because we don't want any complications in terms of thrombosis. But because you don't want anything in the arterial side, no thrombus going, but we can also aim low like 160 or 140 sometimes. And if the patient is bleeding, sometimes we totally switch off the heparin. And APTT we can target 50 to 80 seconds. Anti-10A 0.3 to 0.7, but we don't usually have anti-10A in most of the centers here. So we target mostly we depend on ACT and APTT. And there is no correlation between ACT and APTT or anti-10A most of the times. So we'll have to use a clinic judge a lot how the patient is clinically and then see with how much anticoagulation ACT and all we can accept. The false ACT can be seen in, like thrombocytopenia or fibrinogenemia or hypothermia. So we need to be cautious in interpreting the ACT and make sure that all those problems are addressed before we interpret the high ACT. Um, yeah. So we need to monitor the neurology when the patient is on ECMO. So what we see is usually pupil size and reaction we see. NIRS is the one which most of the centers in the West they use. Here also we use in some places where the NIRS probe it measures the regional saturation of the brain RSO2 it's called. So it's the trend is more important than the absolute value. So if there is a more than 20-25% drop in the NIRS value, which is as compared to before, so that means there is some issue like reduced perfusion to the brain, and so it needs immediate intervention. Like that, you can also use continuous EEG monitoring, or you can also look at in neonates clinically. Look at the fontanelle size. Okay. And if there is no bleeding, the fontanelle, that means most of the time the fontanelle are flat, and you can depend on the fontanelles and pupils, and additionally by NIRS, etc. And the cardiovascular, we always look at the pulse, um, um, pulse pressure, whether the pulse pressure is coming back or not, and there is how the afterload signs of afterload like myocardial stunning. And if the heart is recovering, we also concentrate on the CFT color of the limb and all that stuff. Then renal perfusion we have to concentrate on and look at preventing the renal injury is important. And if there is some renal injury, we have to put them on renal hemofiltration or hemodialysis. Either you can connect to the circuit or to the patient. So prevention of infection and early identification of infection, antibiotic prophylaxis, etc., if required, are important. Then pain and sedation control, because your cannula is hardly like 3 to 4 centimeters inside. In neonates, it's hardly 2.5 to 3 centimeters inside. And if the patient moves or struggles, sometimes the cannula comes out. So securing the cannula is important. Controlling the sedation, preventing the patient to move vigorously is important. Otherwise, the cannula, which is precariously there inside the body, can easily come out. So which can lead to catastrophes. So we need to minimize muscle relaxants, but at the same time, if required, we have to use them to prevent catastrophes. And then, that is all important. And coming back to the again the case. Now, again, we were on zero point 0.4 liters flow. It's come down a little bit with the bleeding. Then again improved once the coagulopathy is corrected. Now what happened is later there was plateau pressure of 33 on ventilator with a pulse pressure of only 4, no ejection. So there's some myocardial staining and pulmonary edema. So what happens? Ideally, central ECMO should have been placed directly on LA vent, should have been used, but it was not used. So diastolic pressure of the LV increased, and then LV perfusion is decreasing as well. So LA vent was placed and LV decompressed. You can see the LA vent here in the bright joined to the venous drainage cannula by a Y connector, and then that goes to the centrifugal pump. So this is the bent LA vent seen. We have we've inserted this, and then this reduced the pulmonary edema. It also facilitated cardiac recovery. So sometimes this can happen where there is some thrombus of the element. So you have to identify if you are not able to get any flows and your heart is distended. If your heart is empty, that's fine. But if your heart is distended, you will have to look into the elevant thrombus and then reinsert it properly. So if you see the slide from Pavlo Miani, this article shows that patients who had ECPR and vent are in green, so they have a good probability of survival. No no ECPR and vent. This is the like no ECPR and vent at all. This is the top one. So as compared to this is low survival, but still it's better because it's a ECPR used with vent. It's a better survival as compared to the rest groups with no vent. And you can also see that in hospital survival is better if you use an L event as compared to no vent. And the deaths after weaning also, they were less in the vented group as compared to the non-vented group. So L event reduces myocardial dilatation, it reduces remodeling and residual dysfunction. It improves the probability of survival by 3 times, and ECPR negatively affects the survival, but if it happens, definitely you will have to use the L event. And percutaneous vent has more complications than surgical vent. However, this risk of thrombosis of surgical vent was present in this study with a need to change the vent in between. So this patient on day 3 had a AKI not responding to the regular hemofilter used on the bypass. So we had to change to CRRT and use a proper CRRT. So where do we connect the CRRT? We connect the drainage of the CRRT, the access of the CRRT post pump, and then return back to the pre-pump. Usually we don't connect to the pre-pump area. So the drainage here return back to pre-pump there. Usually we don't drain from the pre-pump due to the risk of air. So after 190 hours of ECMO run, there was a good pulse pressure in this patient. And there's a, you can see the LA LVR. I can't play videos somehow, but you can see the LA LVR small, like not dilated. The function improved and patient was decannulated on day 8. So coming to some literature, there is this paper talks by Peter Paul, etc., from Switzerland, talks about that this risk factors for post-cardiotomy ECMO are young age, low weight, preoperative mechanical ventilation, arrhythmias, high vasoactive score, and high stat category, and CPB duration and shock. The risk factors for post-op ECMO are the lesions like Roscono, operation surgeries like Roscono, truncus repair, arterial switch, Alcapa, and TAPVC. So the roughly the mortality is like 70% for truncus, whereas it's lowest like 15% for Alcapa. So wherever it's the lowest, we have to be more aggressive. And this paper from Switzerland again, it's a analysis of different studies where it shows that Chaturvedi et al. From Great Ormond Street Hospital and Colvers et al. Have demonstrated that ECMO, if initiated in the operating room, has a better survival as compared to the delayed ECMO, which is initiated in the ICU. So you can see the Kaplan-Meier curve showing the high probability of survival in the in the theater group as compared to the CICU group. So these are all the lesions with cyanotic groups and acyanotic groups where the survival is almost similar, like 45 to 50%, not beyond that. So the only patients in the Chaturvedi et al. Have shown is like the APVC where the 83% survival was there, and arterial switch 67%, and rest all had like little lower, like 50, 20, 30, etc. And the lowest was in tetralogy of Fallot because tetralogy Fallot has some, some issues with the right ventricle and the residual lesions and all. So probably they did not address that. That's why the survival was poor. So here, Maziar, Khorsandi et al. Have demonstrated that as the duration of ECMO increases, the probability of survival decreases. You can see here. And Shaw et al. Have studied in 84 patients where they have identified high arterial lactate at the initiation of ECMO as a high risk factor associated with mortality. And another study from UK has shown that ECMO duration, renal replacement therapy, and neurological impairment and bleeding are the determinants of mortality. So this is a paper from AIMS by Hemant et al. They have shown that residual lesions are very, very important because if you don't identify residual lesions, you can never wean them from ECMO properly. So if you see they have classified into early detection, that is less than 3 days, and then late detection of residual lesions, like more than 3 days. So what are the residual lesions? Like you can see some shunt thrombosis, RVOT, right ventricular obstruction, pulmonary overcirculation, residual PD, valve insufficiencies, or something like that. Pulmonary vein stenosis, pulmonary branch arterial stenosis, or hypoplasia. These are all, if you do identify early, the prognosis is better. Residual lesions delay the weaning, so it leads to longer ECMO duration. And as the longer you keep them on ECMO, the longer you will have more and more problems. So you'll have to do them, you identify by using imaging like transesophageal echo or cardiac catheterization, and then so that you can identify what is the exact problem and try to address and then come out of ECMO as soon as possible. So this also shows that late detection versus early detection, the survival is poor in terms of CPB. Duration was more, in this late detection group. If you see the ECMO duration is high, the decannulation was like it was good in early detection group as compared to the late detection group. Hospital discharge was better in the early detection group. So coming to the shunt group, like BT shunt or PDA stent, etc., where there is a lot of steel happening into the shunt from aorta to pulmonary side. So where there is a too much of stealing into pulmonary circulation, what happens is like systemic circulation will not get much flow. So in that situation, if you put them on ECMO, you will have to give very high flows like 200 mils per kilo per minute. So a study by Phil Botha from, I think this is from Brompton Hospital, where they have studied that predictors of lactate clearance um, are peak lactate during ECMO, neonatal age group, CRRT on ECMO, and shunt circulation, but not the size of the shunt. So basically, if there is a shunt, there is a steal. So your lactate clearance is poor on ECMO. So in that situation, either you have to provide very high flows or give a partial clipping of the shunt. If you clip the shunt partially, there is a chance for thrombosis. So most of the people do high flows on ECMO rather than doing partial clipping of the shunt. Okay. So ECMO in Glen and Fontaine. What is ECMO in what is Glen? Glen is a single ventricle. It's done in single ventricle physiology. So it's a second step most of the times in single ventricle, like hypoplastic left heart, where the SVC is connected to pulmonary artery and the IVC is still left in the original place. So what happens is you are partially removing the upper body circulation, and that means removing part of the venous return and then directly connecting to the pulmonary artery. So there is no ventricle pushing or pumping the blood into pulmonary circulation, whereas it's a passive drainage from the SVC into the pulmonary artery directly. So what happens is if in this Glenn situation, your cannulation can be a bit challenging. Um, like because your upper body's drainage is separate, drainage his body's drainage is going somewhere else, so your cannulation strategy has to be modified accordingly. We'll come to that. So in Fontaine also, Fontaine is the next, the last pathway of the single ventricle physiology surgery. So where we connect the both SVC and IVC both to the pulmonary artery, whereas in Glen only SVC is connected to the pulmonary artery. So you will need more cannulations, yeah, additional cannulas in these single ventricular circulations, where if you put them on central ECMO, suppose you directly go on to the common atrium as a drainage and then aorta as a return. Uh, Even in Glen, you can do that, common atrium as drainage and aorta as return. Whereas in Fontaine, you can directly connect the um, because atrium or the ventricle is not going to help here because all the venous drainage is coming back to Fontaine baffle, Fontaine circuit. So you will have to cannulate the Fontaine circuit as drainage and the return will come back to aorta. If you use peripheral cannulation, that means through the percutaneous, then you have to use internal jugular or femoral vein as drainage and common carotid as a return, or sometimes in bigger children femoral. So additional cannulas can be required, I mean as needed, so that you will decompress the additional venous returns. So, what is the strategy in of the physiology in of ECMO in single ventricle is like again same thing. You reduce the systemic vascular resistance, avoid excessive hypothermia, minimize vasoconstrictor agents, increase ECMO flow to more than 150 ml per kilo per minute. Then restrict the flow in shunts, then adequate decompression of the ventricle, and if there is any conduit or something, you try to preserve the conduit, avoid a thrombus in the conduit so that when you come off, you will not have problems. So in bidirectional Glenn, you will have to first decompress your upper body venous return because suppose you have a high suppose you imagine a eCPR situation. You are in a CPR of Glenn. So SVC is draining to pulmonary artery, IVC is going back to the heart. So if you are not draining the SVC first and you're cannulating the IVC first, then you are doing a CPR, you're pushing against your venous return. So there's a lot of back pressure into the cerebral circulation, which will damage the brain. So what you have to do is first cannulate the SVC and then go back to the IVC and drain IVC and then again cannulate your aorta or the femoral artery. So always cannulating the upper body is first is better in a BDG situation. So you need to also like consider other anatomical uh, things like bilateral SVCs and heterotaxy, interrupted IVC, all that stuff. Because if your IVC is interrupted, you cannot drain anything from a femoral vein. So you'll have to look for a proper cannulation strategy. Screen the vessels by your CT scans or your imaging echoes, etc., so that you will not end up in problems in cannulation in these children with the heterotaxy syndromes and other malformations. So, and also in single ventricles, your saturation targets are only like 80%. You don't need to target 100% on or 95% on ECMO, even on VA ECMO, because if you give too high saturations, you will end up in high pulmonary blood flow situations, which is not good for them because they will have high pulmonary arterial pressures, which will prevent them which will increase the pulmonary arterial pressure, and then that will lead to more pulmonary hypertension, and because that is not good for the passive circulation. So, okay, we already spoke about this. And then sometimes in fountains, we also, to avoid stasis, we also do a VAV hybrid circuit where we drain from the IVC and return into back into both aorta and SVC. Okay, and do not give high afterload because it's a single ventricle. If you give high flow in a single ventricle, it's very difficult to facilitate recovery. So this is just a quick glance that wherever there is additional cannula usage, there is a lot of complications because of bleeding or many other infection or wherever in neurological injury, etc. And wherever there were like high congenital pressures or pulmonary arterial pressures, the mortality was high. And if you see, the mortality is high in the Glenn group as compared to the Fontaine group. So coming to challenges, sizes of vessels in preterm neonates is a big challenge. So we cannot use femoral vessels below 10 kilos. Of course, recently the cannulation strategies are changing, and then people have started using even femoral returns, SVC drainage, and all that is only for VV ECMO, but not for VA ECMO due to small caliber. Then patency of vessels following previous catheterization, other procedures is a big question mark. So we need to keep in mind, look at previous Dopplers and other imagings before we decide on the cannulations, because these chronic patients have a lot of thrombi, which will prevent us in doing any percutaneous cannulation in a chronic patients. Anatomical variations in complex congenital lesions like heterotaxies have to be kept in mind. Need for additional multi-site cannulation in single ventricular and other scenarios are to be thought of. Probability of residual lesions is a challenging issue in post-cardiotomy ECMOs. So in that situation, we have to screen for residual lesions if we suspect them and then try to come out of ECMO. Otherwise, we'll end up in long ECMO runs and complications, and it's going to be a mortality most of the times. Limitations and difficulty in diagnosing lesions is there, but somehow we have to take a risk and balance your anticoagulations, then go on to procedures like CATs and transesophageal echoes if required, but only if required. Bleeding risk in immediate postoperative state is compounded by immature coagulation system in these babies. So that has to be addressed before going to adventures. High blood product requirement triggering fluid overload and systemic inflammatory response is there in these children. Limited range of flow in neonates with no scope or limited margin for error is there, and superflow requirement is there in some situations. And the predictors of mortality from various studies are longer CPB time, inability to separate from CPB intraoperatively, elevated kidney renal parameters within 48 after 48 hours of ECMO, need for blood transfusions and high RA pressures at 8 hours after initiation, a CPR during cannulation, then requirement of dialysis or CRRT, lactate trends within 48 hours of run, and duration of ECMO, a repeat ECMO, and renal mechanical complications on ECMO, and single ventricle palliation. These are all the predictors. Okay, and then this paper from Delhi shows that, so there are some more indications. This is already we spoke. So coming to the summary slide, early ECMO is preferred in low cardiac output to avoid organ injury. But challenges arise. We need to be ready for the challenges and address them due to a lot of issues like immature system in babies, coagulopathy, and also the effect of anticoagulation and cannula related issues. Venting should be considered early in stunning to hasten the recovery. Inability to separate or vein of CPB can indicate serious residual lesion. However, we should not hesitate to go on to ECMO, but always be ready to identify residual lesion. And we need to involve a lot of imaging when as required to reduce the duration of ECMO. Individual strategies for cannulation and ECMO flow should be adapted for various physiologies. ECPR should be performed only in high volume centers, but that too, if effective or efficient CPR is done, effective perfusion pressure is maintained throughout the CPR course until the ECMO or ECPR is established. That's the end of the PPT. Thank you. Any questions,
Thank
please?
you.
Thank
Thank you, Dr. Kishore.
Sorry if I had taken too much time and went into too many details of the congenital heart disease.
No
It's
issue,
okay.
sir. It
This
is
is the
excellent.
topic.
Excellent presentation, sir. Any questions?
Thank you.
Yeah, let's see if any questions are there. No questions in chat box.
Yeah, I can wait for some more time. If anyone wants to ask, we can address this.
Okay, by the time, should I ask one question?
Yeah,
Uh, in congenital heart diseases,
okay.
suppose right to left shunt
Yeah,
or tetralogy or something. So usually HCT is used to be high.
yes.
Suppose
Yeah.
baseline HCT is 250 or 300.
Mm-hmm.
So on ECMO, how much you target?
So
Uh,
you're talking about you see I mean what I've seen is in congenital heart disease with polycythemia,
yeah.
especially where there is polycythemia, there will
Mm,
be this most of the times PT, APTT are reported high
yes.
in the preoperative state itself. So that is like they used what there's a lot of like calibration which happens and then they give a different value later again. But
Oh,
however, we do not really target anything different in this in this population also. It is the same routine targets only we follow.
okay.
So we do not, because that is not actual coagulopathy, it's just the polycythemia which causes derangement kind of thing. It's more of like a technical thing rather than, I think, a
Actual
physiological
problematic.
thing, biochemical change in the patient. However, if it all depends, if clinically it's indicated there is a bleeding, for any patient it's the same we follow. It's like either you switch off the heparin or if you accept minor ooze, go on the lower side of ACTs like 140 to 160 for some time and then again go back to higher side.
Okay. So usual 200, around 200 is
Yeah, at
180
least
to
180.
220.
Yes, at least 180 we keep in
180.
VV ECMO. VV ECMO we keep slightly lower also because we VV ECMO we keep a little flow, higher flow. Here also we keep higher flow, but because it's going into the arterial side, we don't take so much risk. In VV ECMO, it's just going back to the vein, so we are okay with the
Okay.
higher flow. We can manage, so we can keep like slightly lower ACTs.
Okay. Thank you.
Yeah. Any other questions?
Any other questions? Nobody's, I think, taking up. So
I just wanted to know how many of them has idea of like congenital heart disease, or did I speak too much about that, because I have no background information about that. How many people have basic knowledge or detailed knowledge regarding this topic?
they have exposure of congenital heart diseases, most of the students, but I don't think ECMO
Yeah.
exposure is there because
Okay. Fine. Okay.
so
Thank
Dr.
you.
Monalisa, should we
Yes,
wrap up?
yes, sir. Actually, they are MBA, DM, and TRNB students. So this topic is very new to all of them.
Okay.
Thank you,
So
sir.
I hope it is useful to them. Okay.
Yeah, obviously.
Definitely.
Yeah.
This class will be recorded, and before examination, they will repeat. They will listen the classes again and again. So this class
Okay.
is very helpful for all of us. Thank you, sir, for such a
Thank you.
clear, insightful, and
Thank you, sir, for
session.
Yeah.
your
Thank
time
you.
and
Yeah.
elaborate discussion.
Sure. No problem. Yeah. Thanks.
So
Thank you
we
very much.
will look forward meeting you again in our next few episodes.
Sure, sure. Okay. Thank you.
Until then, thank you. Thank you very much, sir.
Okay.
Thank you. Good night to all of you.
Good night.
Good night, everyone. Thank you.